We've now come to the live Q&A of our second session. At this point, we'd like to welcome back Dr. Lim Hwee Yong, medical oncologist, to moderate our Q&A session with our speakers from this session, Dr. Yip, Dr. Tan, and Dr. Lee. Over to you, Dr. Lim.
Thank you very much. Yeah, maybe I'll start off with the first question to Dr. Yip. Yeah, because I mean, as a GI oncologist myself, I see a lot of pancreatic cholangiocarcinoma with obstructive jaundice. And I distinctly remember a patient whereby, he's 82 and a metastat was put in for obstructive jaundice. He happened to be quite responsive to treatment and he lived for 4 years. In the last 2 years, he has to struggle with a lot of stent-related kind of infection, cholangiocarcinoma, and ultimately actually passes on from infection. So I'm very interested that you had this covered stent versus uncovered metastents versus plastic stent. Can you just tell us a little bit about how you decide which one to put in now?
So I think the first step is to decide whether you want to put in a plastic or a metal. So if the life expectancy is 6 months or more, you would tend to put in a metal stent because it lasts at least 6 months, usually 8 to 12, we tell the patients. And for plastic stents, be less than 6 months, between 2 to 5 on average. And between covered and uncovered, there's not, for metal stents, covered and covered, not too much evidence to differentiate the two. But to say that for the uncovered, there's a risk of a tumor ingrowth and obstructs the stent. And for the fully covered, then the risk is that of migration. Yeah, so you have to weigh the two.
So let's say if you put in a covered stent, would you change out the stent every 12 months? Since that it is removable? Or how removable are those stents?
A fully covered stent is fully removable. And we ought to consider changing them. But these are palliative stents. So usually the patients, unless the life expectancy is unexpectedly long, then yes, we do offer a change at 9 to 12 months.
Okay. Dr. Tan, for prostate cancer, I remember when I was training that you used to say that if your tumor is confined, organ confined, then it's a good candidate for surgery. And then if it's a tumor that is with some extra capsular spread and due to the fear of potential positive margins, that might be a situation that we might start to consider radiation. Does the robotic surgery make any difference to the types of or the stage of tumor that you can operate? And also secondly, for the lymph node sampling, does the robotic surgery make it easier?
Okay, so I think there are two parts of the questions. I think for localized prostate cancer and those cancer with extra capsular extension, I think you are right to say that I think very early cancer, I think we do offer surgery. And then in those days that patient will have prostate cancer with extra capsular spread or sent to the radiations oncology because those are difficult to do and then the outcome are not so good. So the lousy cases we send to the radiology, radiotherapists, then surgeon got a better outcome. But those are in the open surgery. I think with the robotic surgery, I think they make things easier to do. You can do a better, even if a high risk prostate cancer with extra capsular spread extension. I think robotic surgery do offer better outcome as compared to traditional open operation because one of the things is that blood loss, intraoperative blood loss. In the open surgery, I think there are significant blood in the operating field. So sometimes you really can't see so well. So it makes the surgery a bit more difficult. But I think the important thing for us is that we counsel the patients. I think about informed consent. I think there are options of doing surgery or doing radiations or plus or minus hormonal therapy. I think it's important to tell the patients.
Okay, maybe I'll ask the next question to both Dr. Tan and Dr. Lee. So it's about patient selection. So now we have two modalities that we can select for a patient with locally advanced prostate cancer. Can you tell us about the pros and cons of choosing with either robotic surgery versus proton therapy? Maybe we start with Dr. Tan first.
So if let's say a locally advanced cancer, so if let's say it's a T4 disease, I think we don't operate. No, I mean, we straight away will say that, no, we counsel the patient, this is not really a good candidate for operation. We send them for radiation oncologist for opinion. Okay, but for those patients who are just like T3, meaning that they are T3A or T3B, that means that extracapsular spreads or seminal vesicles, if you think that the patient is fit, operable, we give them the option of 2. So in my clinic, usually I just tell them the both options and I write a formal letter for them to see the radiation oncologist to say that both options are okay, that you can see, and which one that fit you. I think it's important to let them choose.
Yeah.
Dr. Lee?
So, so Dr. Tan's correct, and there's no definite answer about whether one is preferable to the other. A lot of it boils down to the type of side effect profile that the patient is prepared to accept. So whereas surgery may have a higher incidence, for instance, of urinary incontinence and possibly early impotence, radiation has a higher incidence of rectal bleeding and increased bladder frequency, at least initially. So there are some differences in side effect profile. In terms of efficacy, hard to compare because there's been a lack of randomized evidence. And as Dr. Tan mentioned just now, there tended to be a selection bias in favor of surgery where maybe better, fitter patients were going that way. That could partly explain the better results of surgical series. There is one randomized trial of very early stage prostate cancer that had 3 arms. There was an active surveillance arm, a radiotherapy arm, and a surgery arm. And in that trial, there was no difference in survival between the 3. However, there was a slight improvement in biochemical cancer control with surgery. So that may be some advantage to surgery in that respect. I think at the end of the day, it will be a discussion between the surgeon, the radiation oncologist, and the patient.
I think one of the patients also factors is that I have come across patients that who have prostate cancer, different profile. One patient is telling me that, oh, I'm now retired. I have a lot of times. I come to radiation 6 weeks to 7 weeks. Time is not essence. A patient who come and see me is a businessman. He said I cannot afford to stay in Singapore for 6 to 7 weeks for the treatment. I want surgery, 1 week, I'm out. I can just go back to my career and things like that. So I think there are many factors that we have to factor in.
Yeah, but just to probably add on to that a little bit is that in recent years, the radiation therapy duration for prostate cancer has been getting shorter. So it's true that we used to give about 2 months of radiation on a daily basis but that shortened to 4 weeks or a month with 3 big randomized trials showing equivalence. And more recently, extreme hypofractionation, which is giving high doses in a short period of time, have been able to shorten radiation to 5 days. So I would say that for at least for early and intermediate risk prostate cancer, and even some of the advanced stage prostate cancer, we are able to do the treatment in about a week or 2 these days. Yeah.
Okay, thank you, Dr. Lee. Maybe another question about the proton therapy. Since proton therapy is coming to us in February, can you tell us about how patients can avail of proton therapy? Can somebody come into the GP clinic and say that, oh, I heard of this proton therapy and I really want to see Dr. Lee for the proton therapy? Can they just come in and see you and get proton therapy?
Yes, so I think that's a good thing. So patient will probably be asked to make a referral to speak to one of the radiation oncologists first, and then we will assess the patient case by case and to see, number one, whether radiotherapy is the correct treatment in the first place. Then secondly, is radiotherapy expected or proton therapy be expected to have a superior either efficacy or reduced side effects compared to normal radiotherapy? And if we think that's the case, we will then put the patient up for discussion with a team of doctors in a tumor board, where the doctors will then perhaps sometimes look at the comparison plan of the X-rays versus the protons and see where the dose is going. Is it really going to be superior? And also, of course, it must fulfill Ministry of Health Singapore guidelines on whether this condition is allowed to be treated on proton therapy. And then also the cost is a bit more. And so sometimes patients are self-paying or the insurance may be covered, in which case then all these factors, if everything is aligned, then patients should be able to undergo proton therapy.
Okay, maybe the next question direct to Dr. Yip. With regard to the celiac plexus ablation, when would you choose to do it versus, let's say, generic pain medication, increasing opioids, therapy and all?
Usually these referrals are from the medical oncologists themselves. So after they've failed, maximal opioid therapy, and then they refer to us. We don't get that many referrals, and I must say the evidence for CPN or neurolysis is not that good. Efficacy I showed in the slide, probably 50 to 80%. You can't do it too often, so we don't get too many referrals. Yeah.
Okay. Now, the last question, I will again direct to Dr. Yip. Medical oncologists are getting very demanding over the past 5 to 10 years. When I was starting out in the 90s, nobody cared. Just give me some cells and pancreatic cancer, send home, and enjoy the time next to the sea. So now we want genomic testing, we want all sort of things, want a proper diagnosis and all that. So can you expand a little bit on the recent advancement in FNA versus FNB, which is a core biopsy? And can you get enough tissue for us to do the next-gen sequencing for whole genome sequencing?
I think certainly, because FNB, as the name suggests, you're getting a core tissue, whereas FNA, you're aspirate, you're getting cells. I think with tissue, as you can get many passes. The more passes you get, the more tissue you get, and certainly, I think we can satisfy even the most demanding oncologists nowadays.
Does that increase the risk of, let's say, pancreatitis or infection? And
No, not really. Yeah, infection definitely not, because these are solid tumors. These are not cysts, so there's hardly any risk of infection. Pancreatitis is shown to be the same as the FNA needles. So I think FNB is definitely the way to go.
Okay. So I think we come to the end of the session. So I will close this Q&A and pass it back to the MC.